So the topic I was given was about challenges in the management of hematologic malignancies. And I've gone for many lunchtime talks, and I know it's quite tiring to keep listening to someone talk. So I will keep this quite a lot of pictures, and we'll leave more time for questions. Right? Okay, so the overview of the talk is to give all of us a sort of a background of relapsed refractory hematologic malignancies. And then before we then discuss the current treatment options and the challenges faced, because without understanding the background, it's always difficult for us to talk about the challenges faced. So when we talk about hematologic malignancies, what do we actually refer to? And if you look actually for hematologic cancers, you can be divided into two broad categories, lymphoid and myeloid neoplasms. And these can be further divided into the acute leukemias and the chronic leukemias. Okay, and in addition, I think there's also other lymphomas that we talk about. So apart from the acute and the chronic leukemias, there's also the lymphomas, the Hodgkin's and the non-Hodgkin's lymphoma, and plasma cell dyscrasias such as multiple myeloma. So as you can see, hematologic malignancies are a very heterogeneous part of diseases. And amongst these are the acute leukemias, the myelomas, and the aggressive lymphomas and the T-cell lymphomas. These are the ones that tend to relapse. Whereas Hodgkin's lymphoma, the chances of cure are extremely high. So just to give you some perspective, when we say there's a high chance of relapse, what do we mean? So for acute myeloid leukemia, for example, which is a kind of blood cancer that affects older patients, you can see that even in the so-called good risk patients, their chances of relapse is up to 35 to 40%. In patients who are intermediate or high risk, their chances of relapse can be up to 50 to 90%. And so you can imagine we are looking at a large number of potential patients that may relapse even after treatment. For lymphoma, which is a more curable disease than leukemias, there are prognostic factors that helps to decide how high the chance of relapse is. And you can look, these are things like age, performance status, how fit the patient is, some blood markers as well. And depending on the so-called IPI score, prognostic score, even the worst risk patients as compared to, say, acute leukemia, you can see even the worst patients with the worst prognostic factors, they have at least a 50% chance of cure. But that also means that 50% of patients may not be cured. So again, we have a substantial proportion of patients who have a high risk of relapse. For multiple myeloma, same thing. In fact, myeloma, you can't really cure patients. You just treat their disease and by time, and you can see that the survival curve continues to drop, suggesting that the patients continue to relapse. Okay, and so the key, looking at these few slides, it is clear that hematologic malignancies can and they do relapse, and so there is a sort of a need to come up with good treatment for patients when they relapse. So, and what do we define as relapse and what do we define as refractory disease? So relapse disease is defined as disease that recurs after you have achieved a complete remission, meaning the disease completely disappears, but then it comes back again. And that definition of complete remission or complete response depends on the different type of diseases. For example, acute leukemia, it means that the abnormal cells totally disappear from the bone marrow. For lymphoma, it means that the swelling and the lymph nodes disappear from the PET scan. But the bottom line is they disappear and then they come back, and that's considered relapse disease. In contrast, refractory disease is a disease that never responds. So you treat and the disease never goes into remission at all. So, and therefore, if you can imagine, refractory disease is probably higher risk than relapse disease because the disease doesn't even respond to the original treatment. Okay, and what is the current treatment for patients who have relapsed beyond, what's the second line treatment and what's the treatment beyond? Okay, and you can broadly divide the classes of treatment into four main categories: chemotherapy, immunotherapy, targeted therapy, and then others. Others are like things like surgery and radiotherapy, which are usually not the mainstay of treatment for hematologic cancers because hematologic cancers are more systemic. Okay, and these treatment options can be used alone or combined. Okay, and chemotherapy broadly is basically using a kind of drugs to kill cancer cells, and normal cells are also affected. Targeted therapy is targeting certain mutations, certain proteins that control how the cancer cells grow and divide. And immunotherapy is a kind of cancer treatment that helps your immune system to fight cancer. So using the power of the immune system to fight cancer. So chemotherapy, sometimes it's akin to a bomb, right? The normal cells are also affected. The abnormal cells are also affected. It doesn't identify the enemy from the non-enemy. And the cells that are often most affected are those that are rapidly dividing. So those in the intestine, those in the oral cavity where the cells divide very quickly, the hair follicles, those are the ones that get damaged together with the cancer cells. Targeted therapy, on the other hand, is very targeted. So it targets one area downstream. So for example, this is a FLT3 mutation that drives myeloid leukemias. And so in patients with acute myeloid leukemia with this mutation, there is continuous activation of the downstream pathways. And so by targeting the mutation, you can stop the downstream signaling and hopefully turn the off switch so that the cancer doesn't grow anymore. Okay, and then immunotherapy, unlike chemo, so if you talk about chemotherapy, radiation, normally there's quite a bit of side effects, and after the treatment is over, there's not much protection. Whereas for the new immunotherapy, there's actually better, less side effects because it's very targeted, and post-treatment, there's actually quite a bit of protection as well. So this is a very different new concept of cancer treatment that is gaining weight in recent years. Okay. Okay, and you can see again, less side effects, more post-treatment protection. And if you talk about immunotherapy, and obviously today we don't have the time nor the spectrum to talk about the whole spectrum or all the types of immunotherapy, but they can broadly be divided into what we call antibody therapy. Secondly, immunomodulators, things that affect your immune system and how they fight cancer and their relationship with each other. And adoptive cell therapy, where you actually put in cells or you manipulate the soldiers in your body to come and fight cancer. Okay, so big categories. And these are some of the examples of these categories. And you can see that both for leukemia, myeloma, lymphoma, there are different types of there is increasing use of immunotherapy to treat these malignancies. And so let me give you a few examples. So when we talk about naked antibody therapy, basically, we're saying that the antibody, the front part will recognize the cancer and bind to it. And then the back part will be signal other cells to come and attack. Okay, and that's what will happen. The front part will bind. And then once you bind, you will recognize these cells as cancerous, and the immune system will then come in and destroy the cancer cell. So you can imagine, unlike a chemotherapy, which is not very selective, antibody therapy is pretty selective. Secondly, there's a drug called brentuximab. This is not a naked antibody. So it has, again, the concept of antibody where it binds to the front part that recognizes the cancer cell and binds to it. But it carries with it a cancer drug. So it brings the cancer drug directly to the cancer cells. And again, you can imagine this is more selective. It doesn't harm normal cells that do not express the target. Okay. And what it will do is that it will bind to the target and then it will bring the cancer drug to the cell. Once the cancer drug is released, the cell will be disrupted and die. And so the cancer cells that have that target will then be targeted. Okay, and this drug called brentuximab has been used in first line, second line, and third line treatment for lymphomas, Hodgkin's lymphoma, and he has shown more than 20% improvement in progression. So meaning, you actually can prevent relapses by using these drugs. Next, we go on to checkpoint inhibitors, and I really like this cartoon, and I think this is an extremely important field that is increasingly gaining weight in the treatment, both hematologic and oncologic malignancies. And so what's the concept? The concept is that the tumor cells have a ligand called PD-L1. And what this ligand do is that it binds to a target on the T cell called PD-1. So when the two binds together, they will say, we are friends, please do not attack me. Okay, so it's like, these are the T cells, these are the cancer cells. The cancer cells have a ligand that binds to a target on the T cells. If they bind together, then the T cells will be knocked out and they can't kill the cancer. And so the cancer cells can go around and cause havoc. Okay. So, but even though the cancer cells are clever, I think the scientists are also extremely clever. So what they have done is that they have come up with agents to actually block this interaction. So by blocking this interaction, so either they block the T cells or they block the cancer cells, and by blocking, they will prevent the interaction, and so they are no longer friends, and so the T cell is not knocked out, the T cell is still functional, and the T cells can kill the cancer. And so a lot of cancers use this mechanism to try and hide from the immune system. But the moment you switch off this checkpoint, or we'll call it a checkpoint inhibitor, once you use this checkpoint inhibitor to switch off this connection, then the T cells can now recognize your soldiers, the T cells, which are the cells in your body, the white cells in your body that recognizes the cancer cells, can then wake up and say, oh, look, you are the enemy, and then kill. And it is an extremely powerful tool, as you will see in the next few slides. Okay. Next, there's also something called a bispecific T cell engager. So what this does is that it's like a matchmaker. So what it does is that there's two antibody components. One that brings the T cells or the soldiers to the tumor cells. And when they are together, so in the past, it's hard for the T cells to go around finding the cancer cells, but these matchmakers make it easy for them to find each other. And so they bring the T cells to the tumor cells, and the cancer cells then get killed. Okay, and the first in class is a drug called blinatumomab, which is brings the 19 and 3 CD3 expressing cells together. And so it helps to increase the cell killing. So does it work? I will show you more data in the while. And last but not least, obviously, I think you've heard a few series of lectures from actors. I was looking at the video just now, and you can see there's a lot of discussion about CAR T cells. So what are CAR T cells? Basically, they are cells that you take from the patient's body, expand them, make them stronger, give them a receptor to kill cancer. And I like this picture because it shows you this is a normal cell with a normal T cell receptor, but you put in a virus into them, and you make them stronger and very, very fit, and they can then fight the cancer. Okay, and they are so-called super soldiers, and they have been shown to work quite nicely, as we will see also later. So, but regardless of what you use, whether immunotherapy, chemotherapy, or other agents, I think the aim of all this treatment is to then hopefully, if the patient has a very aggressive disease, possibly bring them to transplant, either autologous, meaning using your own cells for the transplant, or allogenic, where you have a donor. And the concept of a transplant is basically, after the patient is in remission, you give them very, very strong chemo to kill off the residual cancer cells and cure them once and for all. Okay. So this is how we treat hematologic cancer. So it seems like, oh, there are a lot of weapons out there. So why is it so difficult? What are the challenges that people face? And the challenges, I feel, can be divided into 4 main points: disease resistance. And we'll talk about a little bit about, as we treat cancers, a lot of times the cancer becomes clever. It's a very clever enemy. Patients can develop resistance to chemotherapy. They can develop resistance to immunotherapy. They can develop resistance to targeted therapy, as we will see. Then obviously the question is, if they are so powerful, the cancer cells, and is there a way we can identify relapse early and intervene before something else happens, and treat them very early? And we'll talk about that. Then, of course, cost is always an issue. And I think in the papers recently, there was a lot of talk about cancer and chemotherapy and how to keep costs within range, and we'll talk about that. And I think the last challenge faced by the practicing hematologists is, yes, we treat young patients. Leukemias are usually affecting, especially acute lymphoblastic leukemia tends to affect younger adults. So there is always that aim to try to cure them, to do as much as we can to help them. But at some point, I think the physician needs to understand, has the disease reached the stage where you have tried the best option? And if you're going down to the chances of cure is like 3%, 5%, 10%, is it really fair to continue treating the patient without letting them know the poor prognosis? Is it time to stop? And I think these are quite important challenges faced as well. So let's go through one each, and at the end we can still take questions. I think the first issue is about resistance to chemo. So there are, as a practicing hematologist, I know that there are some patients whose cancer are just resistant to chemo, and these are the so-called refractory patients. And a lot of times people have shown that resistance to chemotherapy occurs due to various reasons, and this includes some sort of pump in the cancer cells to push out the chemo before it comes into the cell, some sort of mechanism to break down the chemo before it can kill the cancer cells. And once the cancer cell, the chemo comes in and damage the cell, some cancer cells have the ability to quickly reverse the damage before the cell dies, and so the cell doesn't die. And of course, these are the ways by which the cancer cell becomes very, very resistant. And you can think about it, if you can't get rid of even one cancer cell, that cancer cell can then go on to grow and divide, and and the patient will not be cured. Okay, and so this is data from the Scholar-1 study, which looked at patients with relapsed and refractory, a kind of lymphoma, diffuse large B-cell lymphoma. And what they found was that if you are refractory to first-line treatment or second-line, or you relapse after second-line treatment, etc., you can see that giving more chemo doesn't help. Beyond a certain line, I can give first line, I can give second line, but if you give second line and I give third line, the chances of you responding to third line treatment, for example, is maybe at best about 30%. Then the next line, if you want to give fourth line, is probably about 10%, 20%. So you know that it's like flogging a dying horse. It's not going to work. So at some point, you have to realize, look, this is a cancer that is resistant to chemotherapy. We shouldn't continue to use chemotherapy. And then the question is what to do next, which we'll talk about. Okay, and we need to identify, as a challenge for us, is to identify patients with chemo-refractory disease where you should change treatment. So we really have to think out of the box. And the next few slides, I will show you how people in Singapore have thought out of the box to try to give patients the best chances. So one is something called ex vivo drug testing to allow you, because you have like 5 different options. Each of the options will have 30% chance of cure. So which one you're like tossing a coin. So rather than just tossing a coin and choosing one of the 5, we use a special, the scientists have managed to come up with a special platform to identify out of the 5, which of them are more likely to work so that you can choose the best option. Because the problem with trying to choose more options is that if you keep giving them chemo, the normal cells get damaged, the cancer cells don't get damaged. Eventually, patients are not going to be fit to try all 5 different types of third line, fourth line, fifth line treatment. So you want to narrow down to the one that can give the best benefit, and ex vivo drug testing allows you to do that. Next is to understand disease biology by working too closely with our scientists. By looking at the cancer biology, you can start using non-chemotherapy options, to treat patients rather than just keep giving the same thing which doesn't work. It doesn't make sense to give chemotherapy to somebody if it doesn't work because there's so many side effects. Okay, and there are always so-called non-chemotherapy, immunotherapy options. Okay, so thinking out of the box is extremely important. So let's talk about ex vivo drug sensitivity testing. It's also called a very cool name called QPOT, which stands for not a very cool title, Quadratic Phenotypic Optimization Platform, QPOT, an autoimmune-driven digital medicine platform. And it's developed by Prof. et al. From the CSI and his team. And the aim is to use artificial intelligence, look at the drug sensitivity, and derive the most effective drug combination for patients. And it potentially allows the choice of best drug combination. And Prof. Ed has actually worked with our team, the lymphoma team NUH and the leukemia team NUH as well, to try to come up with use this platform to guide treatment. And this is a case report by Dr. Sanjay Dimel from our group, about one patient, for our first patient that we actually tried this on. And you can see this is a patient who has failed 4 lines of treatment. Okay, each arrow represents 1 line of treatment. And these are the cancer cells. So every time the cancer comes back, the white cell goes up, the white cell becomes very high. So you can see this patient has failed 4 lines of treatment. But surprisingly, when we did the drug sensitivity testing, we identified a combination of using palaminostat and bortezomib that was actually a combination therapy derived by our colleagues from SGH and to treat for T-cell lymphoma. And in the normal context, the response is maybe about 20–30%. But in the QPOT, it showed that it was the best of all the combination used to treat this patient's cancer. So having failed 4 lines, where we would say his chances are very slim, we were able to give him this combination therapy. His cancer cells promptly dropped and became negative, and patient went for an autologous transplant and currently is still alive and disease-free. And you can see he had a cancer called hepatosplenic T-cell lymphoma. His liver and spleen were huge, and then now it's normal. Okay, and he has, at current state, this is about 2 or 3 years out, disease is still in remission. And this is one example where using ex vivo drug sensitivity testing allows you to identify a unique combination of drugs that will best benefit the patients. And you can see this platform, I think since that first case till now, we've treated about more than 30–40 patients, and we are looking at our results from that. I think this is Dr. Prof. Ed Chow. This is Dr. Anand from our group who sort of worked very closely, and I think Dr. Sanjay has also been helping. So I think this is one example where thinking out of the box, trying to come up with good combinations to help patients is so important, rather than just keep doing the same thing. Okay. Next is to identify disease biology. And so there's a kind of T-cell lymphoma called NK T-cell lymphomas, okay, which has been known to have a PD-L1 overexpression. I think you remember this cartoon, right? When we talk about PD-L1, the on-off switch. Okay, so PD-L1 overexpression, and because the cancer has PD-L1 expression, the body's immune system cannot kill the cancer. And so because it will knock out all the T cells. So what, understanding the disease biology, I think the Singapore group together with the Hong Kong group did think about whether is there a role for using this blocking the connections to try to stimulate the immune system to kill cancer. Okay, and this is one of the first patients. This is Dr. Darryl Tan, who used this this drug to treat a patient who had failed like 5 lines of treatment, who was considered palliative intent. But by understanding this, he tried this medication and it worked. And subsequently, I think we've also in Singapore used it, and in Hong Kong we've used it for about quite a few patients. And this was the publication that looked at these results. Again, showing that sometimes you cannot just keep giving the same thing. Understanding the disease biology is so important. Okay, and since then, this drug, PD-1 inhibitors, pembrolizumab and nivolumab, has become standard of care for NK T cell lymphoma which have relapsed. Previously, when they relapse, the outcomes are very, very dismal, less than 10% survival. With this new drug, it's about 50% response rates. Okay. Next, we talk about this matchmaker. So I told you I will show you whether it works. So this is again data from the Scholar-1 study that I alluded to previously, where patients who don't respond to chemotherapy after first, second, third line, they do very poorly. And this is event-free survival. So you can see about 10%, at say 5 years are still alive, 90% are dead. So what people have developed is something called immunotherapy, where they bring the T cells to CD20 expressing cancer cells. And you can see the overall response is amazing. These are patients who have failed every line of treatment. I told you before, with chemo alone, the response is 20–30%, but now you have responses up to 50 to 70%. And even though it's still early days, the results show that the treatment, the duration of is actually a very durable disease response. So very, very exciting treatment, and is definitely superior to chemotherapy alone. Again, reiterating that concept, don't just give chemo alone. Really, if it doesn't work, it doesn't work. It's time to think out of the box. And so again, just to recap on the management of chemotherapy resistance, this is a huge challenge we face, but thanks to the interaction between all the groups in Singapore, as well as the scientific community, we have been able to come up with different ways to overcome these challenges. And therefore, it shows how important that communication is between clinicians and researchers in the field. Okay. So next, we talk about targeted therapy. So targeted therapy sounds very exciting, right? You just target. So this is an example of a drug-sensitive tumor. It depends on this mutation, RAS mutation downstream, to cause proliferation of the cancer cell. So it does seem idiot-proof, right? You just block this and then everything stops and cured. But the problem is that you will realize that targeted therapy often isn't so straightforward. And after a while, the doctors are clever, the cancer may be cleverer, where the cancer may come up with other pathways. So you block this pathway, they come out with another pathway to stimulate downstream. You block this pathway, they may activate downstream. So even though you block upstream, but downstream is activated, there will still be downstream signaling. And so through these mechanisms, you realize that a lot of times, especially for the more aggressive cancers like acute leukemias, the targeted therapies only buys you a short window, short remission, and it's not meant for cure. It's meant to bring you to a bridge to transplant or cell therapy or whatever. Okay, so that's something important to realize. So it's a challenge. The challenge to the hematologist is to understand this theory that you are not curing these patients often with targeted therapy alone. It's just a bridging you to something better or different. Next, immunotherapy sounds very exciting, but yet despite it costing, the commercial CAR T cell therapy costs $500,000, just the drug alone. And yet despite that, there are some that doesn't work. And the question is, why doesn't it work? And if you look, it's because, for example, why do patients get resistant to CAR T? And there's two mechanisms. One mechanism is antigen escape. So this is a CAR T that recognizes CD19 on the cancer cell. So by binding together, so it comes to it, binds to it and kills it, right? Killing signal and kills it. But the cancer is quite clever. So it may modify this receptor so that it doesn't bind to it anymore, or it may bring these receptors downstream and hide it. So because there's no receptor, when the CAR T comes along trying to kill, they realize, hey, I cannot find the enemy anymore. So there isn't that killing signal, and that they cannot kill the cancer. So that is the main mechanism by which cancer cells can escape CAR-T. Okay, and secondly is so-called the lack of expansion and the persistence of CAR-T cells. And what happens is that because patients have, T cells are just soldiers in your body, and if these patients have been given with a lot of chemotherapy before, the soldiers are already weak, they're already tired, and so even though now you try to make them super soldiers, I mean, if you give a 80-year-old a big gun or a cannon, you still cannot make them become a super soldier, right? There's still that weakness. Okay, so what people have tried to overcome these so-called challenges is, firstly, they have come up with the option of giving, instead of one target, they have two targets. So if they suddenly lose this target, there's still another target that you can aim for. And they do it either by using two different CARs that they put together, or one CAR that expresses two guns, two different types of guns that can recognize two targets. Okay, and secondly is to try, the scientists have also found that if you can, Prof. Dario Campana's group have shown that you can actually incorporate what we call erythropoietin receptor into the cell. And by doing that, these cells, the weak or the weaker T cells that may not expand so well, now have a receptor. And when you then give these T cells erythropoietin, they can bind to the receptor and make the T cells stronger. So first you make it stronger, then you give them the gun. Or, it's like giving the 80-year-old a potion to drink to become younger, and then the 80-year-old can then carry the gun and go and fight. Okay, so that's a brilliant concept. And so I think, it's constantly that challenge, trying to identify why the cancer cell is, being able to fight the cancer, and then going forward to try and break that cycle. So that's the challenge both a hematologist and oncologist face. When you treat cancer, the cancer cells are clever. So you constantly have to innovate to try to overcome the challenge, their cleverness, and to still try to kill them. Okay, so that's the first part. And that's, I think, the key challenge faced by any practicing hematologist or oncologist. The next question is, should we intervene earlier? Is there data to suggest that intervening earlier will help? And so there is this new concept in acute lymphoblastic leukemia, the childhood leukemia, where if you identify what we call minimal residual disease, you can identify patients at risk, and you can pick these patients up, they are going to relapse. Then I think the question is, can we treat these patients before they go into frank relapse, and you lose that chance, that window to treat them? Okay, and there is some data. One is using blinatumomab. So blinatumomab, if you remember, is the first in class by the matchmaker. So people have used blinatumomab when patients relapse, and yes, they do better than chemotherapy, but you see the curve is still not ideal. It's about 30%. So when you wait until the disease is frank relapsed, even if you give this new drug which brings the cancer together with the T cells, the soldiers, yes, it does do better than chemo, but it's a bit late. By the time 100% get cured. Okay, but in recent years, people have actually given blinatumomab earlier. So if you do minimal residual disease and you see that the residual disease is starting to climb up, and what people have done is to just give the blinatumomab straight away. Or if you treat the patients, finished all their chemotherapy, and yet at the end of treatment, there's still clear there's still clear minimal residual disease, then you might just give the blinatumomab to eradicate the minimal residual disease. And the results have been quite clear that it works. And so therefore, blinatumomab has been now approved for minimal residual disease, and not just at the time of relapse. Okay. Another example is the Malaysia-Singapore protocol, pioneered by Dr. Allen and his colleagues from and working together, his colleagues from KK as well as Malaysia. And what they did was that they came out with a chemotherapy protocol, but understanding that it's important to intervene earlier, they have time points, minimal residual disease, earlier time points, and various time points. And the aim is to try to identify, oh, you are a bad player, I'm not going to wait until you relapse, frank relapse, I'm just going to sit there and keep giving you the same thing. They have like a pass-fail. So it's like primary school, secondary school, right? You pass, you go on to the next stage. If you don't do so well, then they quickly start tuition, or they give you more chemo rather than the standard chemo. And if you still don't do well, then they might do special things to get you into remission and then bring you to a transplant, because you have proven yourself to be a bad player. Okay, and does it work? If you compare hypercivet is what we used to use for our old young adults, the young kids who had ALL, like 18 to 20, and or 18 to 30 or 18 to 40. And you can see that the outcome was about 30–40%. But now 5 years progression-free survival. But now with this new method, you can see that the survival is much better. And it is very impressive and data. And I think there is no question that intervening earlier may help to prevent you from having to do it at a later stage. So I think the answer to this is yes. And the challenge phase is to identify markers to be able to allow you to intervene earlier. Okay. The next question is about cost. So I think most of you, if you read the Straits Times, they love these titles, right? Leukemia drug for boy cost 150,000. And this drug that they talked about was actually the first-in-class BiTE therapy when it first came out, 150,000. And then now, of course, 150,000 compared to CAR-T, commercial CAR-T, 500,000. Oh, this is actually cheaper. Okay, but these are very costly drugs. So thankfully, with the new sort of MAF, MediShield Life, MediSave options, the HSA and their team have tried very hard to identify drugs where it's cost effective. And so this gives them, they will work with the drug companies to try to bring the cost down. And for those drugs that are really effective, they have tried to use MAF, national sort of insurance to try to help the patients to pay for these expensive drugs. And I think it was covered quite extensively in the Straits Times. Obviously, not all drugs are covered at the moment. The question obviously is what is considered cost-effective therapy is still a work in progress. But clearly, I think this is the way to go because, this is the way that allows us to try to identify new drugs that will help patients. And you can see this is an example that was put up. If we can get the drug company to reduce the price of the drug, then together with MediShield Life and MediSave, there may be less out-of-pocket treatment. The good thing about this, obviously, is allows a bigger options for patients who would otherwise have to pay more. The bad thing about this, however, is that there are certain drugs that might not fulfill this drug cost-effective therapy definition. So, for example, if you look at the previous pembrolizumab drug and all that, it's a bit hard to think out of the box for patients who do not have the ability to pay. But it's always that flip side between trying to make it cost-effective, versus trying to help patients. So it's still an ongoing process. But I think this is a very good first step, and I think overall, it will help our patients. Okay, so cost-wise, I think there is work to try to do more. All right. And the last part, I think, by the practicing hematologist is the key question. Is it time to stop? When is it, time to say enough is enough? And a lot of times, we focus a lot on curative treatment. As a transplant doctor, myself, I treat a lot of patients. And a lot of times, when we treat patients, our aim is to cure them. And yet, at some point, you realize that the disease just cannot be cured. Even with all the medications out there, with all the research out there, there are patients that they have reached the end of the road. And then at that point in time, it's important to identify that this is the end of the road. You should try to do minimal to give quality of life. That the aim moves from curative intent to quality of life. And that sort of transition is so important because if you give up too early, then you might actually, for the other patients, you can see, right, 4 lines of treatment. If you give up too early, then the patient might have lost the chance for that treatment. But if you give up too late, then the patient might not have the chance to appreciate that he or she is actually dying. And so, you can imagine there's always that struggle and that what is the best time to give up, or maybe you don't just give up, but you try, but you constantly talk to patient and let them know that this is a very bad disease, we are trying, but don't give them false hope. And that's so important. Okay, and that is a huge challenge that a lot of people don't realize sometimes, or we don't mention. Okay, and eventually, if really there is no further treatment, it is important to walk that journey with the patient, not just say, oh, sorry, I can't treat you anymore, I feel guilty, so I'm going to send you to the palliative physician and then not see you anymore. I think that's also something that we don't do. Okay, and the good thing is that healthcare systems, understanding that this is a challenge phase, have come up with things like advanced care planning, disease-specific planning, preferred plan of care, where they have done much to try to identify options to help patients throughout, even when the patients are diagnosed with a cancer, even before we say the cancer is, maybe the cancer will be curable, but you start that conversation early. You identify it, because it's always difficult when the patient is in a comatose state for the family to make that decision for them. Okay? And so if I could just recap, today we talked about what is relapsed refractory cancers. We talked about the treatment options available, and then we talked about the challenges faced and the solutions that we have. And so I hope that today's lecture gives you an overview. It's not meant to be comprehensive, but it just gives you an overview of the challenges faced in treating patients with hematologic cancers. Okay, so thank you, and I'll be happy to take any questions. I just wanted to, before I end, to thank everybody, my friends, my colleagues in NCIS, nursing, doctors, everybody, Allied Health. I think we have a very good team, and I'm grateful for all the support for our patients. I also want to thank all the hemato-oncology colleagues in Singapore. We work as a very close community, and I'm grateful for that. Special thanks to researchers who bring new hope to patients, and of course, most importantly, for the patients that we care for trusting us to take care of them. So thank you very much. Any questions?
Thank you, Dr. Michelle. So we will now proceed with the Q&A session. So Dr. Michelle, you have 2 questions in the Q&A.
Sure. Do I look under the chat or?
It's under the Q&A window. Yeah.
Sure. Sure. Okay, so the first question was about targeted therapy. So I think maybe I'll just read out the question. It says, since targeted or therapy, immunotherapy are better, are there still roles for second-line chemotherapy such as DHEP and RICE? Why not just skip those? That's an excellent question. And I think that the problem with trying to just skip those is that we know that they work, they are better in terms of less side effects, but a lot of them, the follow-up is still short. And so actually there are studies ongoing. So there are 2 studies that have tried to bring the Belinda study and another CAR-T study, which have tried to bring CAR-T to the second-line setting. So meaning after you fail first-line therapy, they then bring CAR-T to the second-line setting. And I think one was a positive study, one was a negative study. Or negative study in the sense that they wanted to show that it was superior to DHEP, RICE, or to chemotherapy for second-line treatment. One was successful, one was not. So the simple answer to this is, number one, it's expensive. Trying to bring immunotherapy itself is costly, right? CAR T cell therapy costs 500,000, transplant costs 100,000. So cost is an issue. Secondly, that's because there's more data for chemotherapy, whereas the CAR T cells, etc., it looks very promising, but the data is still sort of premature. And I think we need more time to see whether it works. We need big trials to actually identify this. And these trials are actually in progress. There's a bispecific trial that compares against standard of care chemo. There is a CAR-T that against standard of care. So I think we are waiting for these trials to be mature before we change the therapy. Okay. The next question is QPOP. And this is a really, really excellent question from probably somebody who understands the whole healthcare cost system. So the question is, does the use of QPOP selected drug, is it under subsidy, under the Medishield drug list scheme? The answer is no, it is not under the new okay, it depends. So there will be drug combinations in the QPOP. Some of these drug combinations will be drugs that are licensed for use for cancer, and in which case then it will be in the Medishield drugs list scheme, but there will be drugs that are in that combination that would not be covered by the Medishield Life scheme. Then what happens then? Well, firstly, I think we are trying to get a grant, a national grant, to try to see whether these costs can be, at least the initial costs can be subsidized, and if there is benefit, then I think we can then apply for MAF Plus for help. And then I think 2 is to hopefully, once we can show a certain particular combination actually constantly shows benefit, to try to work with the HSA to try to get these drugs into listing. But it is going to be a challenge. I don't disagree. And that's because, that's that balance between cost effectiveness versus being unfair to make other people pay for an experiment, right? Okay, so I don't have the best answer, but we are trying to get funding for this. Okay. Why is chemotherapy always used as first-line treatment? Because I guess historically, chemotherapy, lymphoma cells, cancer cells, leukemia cells are very sensitive, and they are because they grow very quickly, so they are always sensitive to chemotherapy. So they are normally the mainstay of treatment for hematologic cancers. Will they eventually be always the first line of treatment? The answer is may or may not. There may be more studies out there, but at the moment, I think most cancers, chemotherapy still remains first line. And what is your take? And the next question is about, to know, it's heartwarming to know that we have so much advanced treatment, and I completely agree. We are really grateful for all the scientists, everybody that have helped us with our patients. What is your take on our current state in drug efficiency monitoring with regards to blood cancers? I'm not sure when we talk about drug efficiency monitoring, do you mean drug levels? Well, I think there are sort of drug level monitoring testing for certain drugs, but I have to admit that there are some drugs that we still don't have the capability of monitoring. There is also a research study by, I can't remember, I think it was Dr. Dean who it's called the Curate platform, where they try to do drug testing to see what is the level of drug that you need to cure cancer. Do you really need so high levels, or can you actually get away with smaller levels? I hope that answers the question as well. And then yet another question, can I ask why autologous transplant is usually done in the initial approach and not allogenic transplant for lymphoma and myeloma patient, or it may not be for all cases? So this is also a good question. So autologous transplant compared to allogenic transplant. So autologous transplant is transplant from using your own cells. You collect your own cells, you keep it, you give strong chemo to kill off the bad cells, you put your own cells back in. So the reason why autologous transplant is favored over allogenic transplant for lymphoma is because there has been a randomized study that have shown that autologous transplant is better than chemotherapy alone. And there have been studies that have shown that in the second, when the patients first relapse, auto versus allo, there's no difference in outcome. And the reason why there's no difference in outcome is because the allogenic transplant, meaning using a donor cells to do the transplant, there's usually less relapse. But even though there's less relapse, there's higher toxicity because it is more toxic, right? You are putting somebody else's cells into you. There's always that risk of attack. The patient, the other person's cells may attack the host and cause graft versus host disease, etc. So allogenic transplant is more high risk than auto transplant. And so because allo is more high risk than auto, number one, that balance, you may have less relapse, but you have higher treatment-related mortality. And so eventually the randomized studies show there's no difference in doing auto or allo. And in which case then obviously you go for what is safer, which is autologous transplant. But are there exceptions? There are, like for example, certain T-cell lymphomas, they are so high risk that you know that the relapse is so high that you're willing to accept the risk of allogenic transplant, and you might do that in the first line relapse setting. Okay, so I hope that answers the question. Any other questions?
And Dr. Michelle, you have one question in the chat from Miss Michelle Fergunas.
Oh,
given the challenges you just outlined in answering the first question, how far do you think we are from chemotherapy-free first-line treatment?
Yeah, I think first line would be, we are a long way away. If you're saying second line, I think there are many trials that are actually addressing meaning second line, meaning first line is standard chemo, right? And then second line is when you relapse. The first line salvage or second line, whatever you want to call it, means that after the patient relapses from standard treatment, that one, I think it is extremely promising because there are many trials that are already ongoing, specifically looking at this question. And I believe that in the next 5 to 10 years, things will definitely change in terms of the first line salvage. But first line therapy, I think we're still a long way to go because most people would rather go for the what we call the low-lying fruit, right? You want to get your drug approved. You don't want to try and fight against chemotherapy in the first line setting. If for example, Hodgkin's lymphoma, the cure is 90% and the immunotherapy comes along and wants to prove that it's 100%, it's going to be hard. So most of the time, the drug companies go for second line where, the outcomes are not so good with standard chemo. So you want to go in there and get a niche and earn money. they don't go at the start where, you know, it's harder to prove efficacy and harder to get licensed. So, but I think in the second line setting, definitely in the next 5 to 10 years, I foresee that when the results of these ongoing trials, which we a lot of centers in Singapore are involved in, once these results come along, I believe that there might be some change in practice. So that's again an excellent question. Okay, and then I think there's a question from William Xu asking about cell-free DNA. No, I completely agree, and I think cell-free DNA is trying to look for cancer DNA in the blood rather than, you know, having to do scans, having to do bone marrow studies, but rather looking at cancer DNA within the bloodstream. Can it be a future tool? I truly believe it can. I don't know how long it will take. You know, about 2 to 3 years ago, when I went to Lugano International Lymphoma meeting, they were talking a lot about cell-free DNA. 2 years later, they're still talking about cell-free DNA, but nothing has come into clinical practice. So I'm not sure how long it will take, but I believe that it will be a future tool to guide early intervention. And just as an aside for fun, you know, I was talking to a renal transplant colleague recently, and in US, they are already using cell-free DNA to identify renal rejection and to guide treatment. So I think in the future, when it becomes a bit cheaper, easier to do, you know, possibly it will be used to guide early intervention. Again, another excellent question. Okay, any other questions?
Okay, I think we can go for one last question. That's also in the chat box. That's from Mr. Manfred. Do you see the question, Dr. Michelle? Excellent presentation.
Manfred, yes, thank you. Continuing on discussion, auto versus allo, haplo. Yes, so again, you know, this is a question close to our heart. So haploidentical transplant is actually transplantation from somebody who's not a full match, but a half match. And I would say in the last 5 to 10 years, it has gained traction and in terms of an option for transplant for patients. So haploidentical transplant has been compared to fully matched transplants, and in a lot of settings, it's actually been shown to be quite comparable. So we would use haploidentical transplant over cord blood transplant, which is another option for patients who have no matched donor. So if somebody has no matched donor, the options are haplo or cord blood transplant. Okay, and between the two, increasingly all the data suggests haplo is probably largely better than cord blood transplant. So most people would prefer haploidentical transplant. Maybe there will be new data that then helps cord blood to win, but at the moment, haplo, still the data seems a bit more promising. And haploidentical transplant is particularly good for lymphomas because in fact, if you look at some of the studies, they even suggest that haplo is actually better than full match allo for Hodgkin's lymphoma. But I would say the data is still premature. So to answer Mr. Manfred's talk, I think number one, I would do haploidentical transplants for patients who have no donors, and if they have, you know, they have a right indication. But because haploidentical transplant is also associated with more risk, I would think very hard before I use haplo, the way I would think very hard about using an allo for a lymphoma relapse, for example. Okay, thank you.